Well, thank you very much. It's good to be with you all today. This marks the 52nd year of my career in behavioral health. And I've done just about anything anybody can do in this business at one time or another. Um, my career started in 1971, finishing graduate school with a master's degree in social work. The Vietnam War was raging at the time, and I was an officer in the US Air Force. And because of the drug problem coming out of Vietnam, I found myself being assigned to the responsibility of setting up and managing an outpatient drug treatment program, because in those days, the military had no treatment capacity whatsoever. So it's been a long ride. I don't believe in retirement, so I often say I hope I'm wise enough to know when I'm not good at playing the game anymore and don't have to wait until somebody decides to carry me off the field. I'll walk off voluntarily on my own. By way of further introduction, I'd like to start out with a story, if I might. If you think of career choice and career development as a pipeline, what gets us to the point of even entering that pipeline? I grew up in 1947, is my birth year, and my father disappeared when I was 2, never to be heard from again. And my mother was a high school dropout. She waited tables to make a living. And in order to be able to afford to live, we lived in a government housing project. And I certainly wasn't thinking necessarily about what I wanted to do when I grew up. In elementary school, I got mostly all A's because it was seemingly easy for me. I didn't have to put any extra effort into it, but by the time I got to what then was referred to as junior high and today middle school, I had to crack a book once in a while or do a paper or study for exams. And that got in the way of running the streets and having what I thought was a good time. And I really wasn't interested. I was only interested at the point to do enough to get by without necessarily failing out. And back in those days, the boys all took shop classes and the girls took home economics. And I had taken wood shop and metal shop. And at this particular point in time, I was taking a drafting course, learning how to draw blueprints, which I was getting an A in, one of the few courses where I was performing at that level. And our English teacher gave us an assignment doing a paper on what we wanted to do when we grew up. Well, since I was liking this course on drawing blueprints, I did mine on being an architect. And my best friend also was in that same course, and he did his paper on being a social worker. And before turning in our papers, we each read each other's papers. And when I read his paper, I was like, it blew my mind. I said to him at the time, "You mean somebody will pay me money to help people?" And he said, "Yes." And the bells and whistles went off for me. And I knew immediately that that's what I wanted to do. I often think back, had I not read that paper in the 9th grade, I don't know necessarily what would have become of me. It wasn't enough at the time necessarily to change my behavior any. And I got to my junior year in high school, and they had a career day, and they had different professionals assigned to different rooms. And I looked on the roster to see if there was somebody representing social work, and there was. And I went to that room, and I don't remember much about the content other than one key message. This woman said, today, if you want to be a social worker, you've got to go to college. Nobody in my family had ever gone to college. I had no conception of even what college was. I had never been to the guidance counselor's office, but immediately after attending that session, I went to the guidance counselor's office and I opened the door to the office, and a woman stopped me and said, "Can I help you, young man?" And I said, "Yes, I just found out I have to go to college. Tell me what I have to do." And she says, "Just a moment." And she goes and pulls my file and she's got it open. She comes back and she's nodding her head. She said, "I'm really sorry to tell you this. But she said, based on your academic performance to date, I don't see any way you're ever going to get into college." And I said, "Come on, there must be something I can do." And she said, "Well, perhaps if you get all A's your senior year, you would apply to some colleges, maybe you'll get lucky." So I heeded those words, and my senior years, I got all A's and one B. I applied to one school. I grew up in Cleveland, Ohio, and I applied to Bowling Green State University because I thought the name sounded cool, not because I even knew it had a relevant course of study. And that set me on the pathway to being a social worker. There's a lot more to that story, but I won't belabor it currently. But I'd like you to think about, what launched you on this trajectory of being in the behavioral health field. It's different for all of us. And if a young person is exposed to the kind of serendipitous experience that I was, they don't necessarily know what their career options are. And even today, if they do, the incentives oftentimes are not in the right place to really incentivize pursuing that trajectory, if you will. So let's move on from there. These are learning objectives for this afternoon, to identify how to determine the capacity of a behavioral health workforce within a state or even a county, to restate the 3 barriers to a consistent behavioral health workforce, to discuss broadening the concept of solutions to address these needs, and to give examples how to quickly impact workforce availability and retention. The reality is, and this is an old adage, that you can't manage what you don't measure. So if you don't understand what the capacity challenges are relative to the behavioral health workforce, you can't begin to really problem solve around how to find solutions. My last job, in essence, was as the behavioral health commissioner for the state of New Mexico. And I served in that capacity for 5 years until May of 2019. And then I came to work for RI International, where I serve as the vice president for business development and consulting. And one of the unique things that New Mexico has going for it with regards to this particular challenge has to do with a statute that was passed almost a decade ago now, which legislatively mandated the formation of a healthcare workforce committee. And that committee was given the authority to survey annually all of the professional licensing boards in the state to understand exactly what the capacity of each of the various disciplines are at any given point in time. The committee is overseen by the University of New Mexico, their Health Sciences Center, and it conducts this annual survey and then issues a report in October of every year to the state legislature on the capacity needs statewide, and further breaks down capacity by each county in the state against projected needs. And so this isn't solely restricted to what we think of traditional healthcare. This includes behavioral healthcare as well. So when you look at that report, you can look up any county in the state or statewide and look at a profession, whether it's psychiatry, psychology, social work, counseling, marriage and family therapists, etc. Everything with the exception of peer support specialists. There's collected data and a set of recommendations around how to overcome workforce shortages where they exist. And you'll find a great deal of disparity. In New Mexico, Albuquerque is the major population center. It has a medical school, and it's where the greatest concentration of behavioral health professionals are. If you move down to the second largest urban center, that's Las Cruces, New Mexico, they're much more challenged. Here in Santa Fe, which is the state capital, we're much more well endowed as a place, as opposed to a place like Moore County, which has more cattle than it does population. So why is this important? Well, the reality is that because you know how many are professionally licensed by whatever discipline in the state really doesn't tell you who is available to actually serve as a behavioral health provider. The reality is that somebody can move to another state and elect to maintain their licensure in the state that they departed from to keep their options open. Should they ever decide to return, they wouldn't have to go through relicensure, etc. The same goes for retirees. A lot of people retire from a given profession, but keep their licenses active. You also have a large percentage of folks who are working in other capacities. They may be in management and administration. They may be in academia, and they're not available to practice either. In New Mexico, relicensure for all disciplines by the various licensing boards occurs every 3 years, and those are staggered. So not everybody every 3 years submits relicensure applications at the same time. But over the course of 3 years, you actually have the entire discipline surveyed and understand what the actual capacity is to be able to be a service provider. And again, you can look at this statewide or by county. New Mexico is the only state in the country that has such a structure to collect this kind of data. Now, a set of recommendations is always made by the committee to the legislature. And unfortunately, the legislature, in all of its wisdom, doesn't necessarily follow up with the kind of comprehensive policy recommendations that it would take to adequately address what I consider to be the #1 challenge in our field. So what are the barriers relative to having adequate workforce capacity? Everybody seems to acknowledge that there are tremendous challenges around recruiting providers and retaining them as well. And employee turnover has been exacerbated over time. I'll be referencing some information here in a minute that's actually a decade or more old, at which time we had 20 to 70% annual turnover in the behavioral health profession nationally, and that's only gotten worse. As a result, there's not enough workforce development that goes on. There's immense pressures on those who stay behind. We'll talk a little bit about increasing service demands, increasing intensity of needs, etc. So that one of the first things that oftentimes goes is the cost of carrying a robust workforce development program. Special populations needs exist across the spectrum. If you think about services to children, youth, and families, they are in short supply. Try to recruit for a child psychiatrist or child psychologist. You have to pay tremendous sums to recruit and retain them. We have never had the representation in any of our professional discipline to represent the communities that we serve. So if you look at data regarding, how many African American psychologists and psychiatrists we have, or Asian, and we could go through every marginalized community and find that we've got a long way to go to have a professional capacity that those in marginalized communities can identify with. There are also tremendous geographical challenges. Here in New Mexico, we have a very large rural and frontier area. We're the 5th largest state in the country, but we're also a very poor state. So that we've had at times almost 50% with Medicaid expansion being enrolled in Medicaid, and 70% of all the births in the state are paid for by Medicaid. And we have often been at a race to the bottom on just about every measure having to do with child well-being and health outcomes. And I could go on and on. Kind of a race to the bottom with states like, Mississippi and Louisiana. When I came to work as a behavioral health commissioner here in New Mexico, people kept asking me, what's your vision for behavioral health in New Mexico? And my common refrain was, that's akin to asking somebody on Maslow's hierarchy of needs who hasn't got anything to eat, what they're going to do to become self-actualized. The reality is that New Mexico, like most states, has had all kinds of system reform initiatives, and yet the same problems seem to persist year after year. So my goal was simply, how do I get food on the table? How do we identify what the problems are in New Mexico, and how do we begin to adequately address them? And I'll talk more about that in a bit. Likewise, training is oftentimes one of the first things to go when organizations are financially stressed. Supervision can often be inadequate. Succession planning can go out the window. The kind of supports that staff need and be able to adequately be prepared to do holistic care and operate in integrated care settings all seem to erode over time and go by the wayside. So let's talk about what might be our strategic goals around addressing all of that. And before I get into that, I want to make clear how challenging things are. And the Annapolis Coalition, which grew out of the American College for Mental Health Administration, issued a report back in 2007. And here we are in 2023, calling for national policy initiatives to address what they identified as the behavioral health workforce crisis. If you think of yourself as a young person today who's just finishing undergraduate school, and what their average student loan debt is, and you're thinking about going on to graduate school, what makes the most sense in terms of return on investment? Do I go to graduate school and get an MSW or get a master's degree in professional counseling? Or do I go to business school and get an MBA? Where am I going to have the sufficient income to adequately pay off the student debt load that I am carrying? And it's kind of a no-brainer. So young people, in addition to tending not to enter the helping professionals, because whatever worldview they might hold, the incentives simply are very well misplaced. When I talk about this, I think about a woman who worked for me back in the 90s. She was in her 30s. She had a independent license as a social worker, and her dream had always been to be a physician. And so she decided that she was going to act on that dream that she had put off for so many years. And as she began to investigate taking that path, she quickly learned that she didn't have the requisite coursework from when she was in undergraduate school to ever even be able to apply to medical school. So she had to go back and take courses in anatomy, organic chemistry, advanced math, etc., so that she could even apply. Once she jumped those hurdles, she began applying for medical schools and found there was no medical school in the country that would accept her. So she ended up applying to the medical school in Grenada in the Bahamas and ended up attending there, and then had to serve her residency. Now, this entire time, she was utilizing student loans not only to pay for her education, but also her living costs. When all was said and done, by the time she'd finished her residency, had elected to be a primary care physician, she had over $1 million in student debt. And I can remember her talking to me at the time. She said, if I had known this is how it was going to be, I would have never started this journey in being a physician. She said, in my lifetime, I will never make enough to ever pay off my student debts. And too many young people are saddled with that kind of burden. In addition to that, baby boomers like myself, are leaving the field every day at increasing numbers. It's been further exacerbated by the COVID pandemic. So when you look at people entering the field, they don't begin to compensate for those who are exiting the field, which puts increasing pressures on those who remain behind. Burnout, I think, is worse than ever before. And when you add to that the inequities that exist in our society, this seeming sense of despair that seems to pervade us all. And we see it exemplified by the increasing rates of suicide, homicides, school shootings, chronic illness, the list goes on. And so I really get why young people can feel increasingly hopeless. And let's add, the global climate change on top of that, what's going on with the economy, the war in the Ukraine, etc. It just seems to be one trauma on another piled on, beyond which a lot of people can, in fact, cope. And we never seem as a society to be able to get upstream to look at what do we do as a society who's increasingly suffering from despair. We always seem to put the bulk of our resources on the back end, offering treatment, not enough prevention, early intervention, etc., very late. And it ends up costing us immensely as a society. Let me move on. So we want to be able to broaden the concept of a workforce, and we've certainly seen this increasingly with the advent of employing people with lived experience. Here at RA International, we've been a real pioneer with employing and advocating for peer support in our behavioral health workforce system. We did some of the initial research They contributed to SAMHSA recognizing peer support as an evidence-based best practice. We're only second to the Veterans Administration or the Veterans Affairs Department today in the number of peers that we employ. Over 50% of our workforce are people who identify with having lived experience, and we're the largest trainer of certified peer support specialists on the planet. Basically, we've to date trained over 17,000 individuals as certified peer support specialists. We're the entity that does that for roughly 14 states around the country, and we've done this for a variety of other countries as well. And it's critical if you're going to employ peer supporters, as we sometimes call them, to not just employ them, but supervise them in a way that further nurtures them and keeps them passionate in the work they do, but pay them appropriately as well. And too often, the pay rates are far from a living wage. And we've expanded peer support specialists increasingly around the country to not be limited to adult peers, but also family peers and youth peers. And some states now, including New Mexico, are beginning to offer specialty credentialing for peers so that those who are first responders, work in law enforcement, our veterans, etc., they can have specialized credential as well. And we advocate for expanding community involvement. Too often, communities suffer the after effects of not having an adequate workforce and adequate services to meet their needs, and they wait for the state or the federal government to come in and solve those problems. But there are a lot of things that can be done at the community level, and I will touch on that some more in a bit. And we want to strengthen the existing workforce. But again, it requires that there be able to be the resources to do any of the things relative to the goals that are represented here. The reality is that for decades now, most providers have been reimbursed through fee-for-service. You deliver a service as an organization, you're contracted with different payers, whether it be Medicaid, with managed care organizations, commercial insurance, etc. You go through all the machinations of appropriate documentation, billing coding, you submit claims, and you get paid after the fact, presumably. And there's a lot we could talk about the challenges around that. But as costs have continued to increase, reimbursement levels for organizations, providers have not. So the only way to compensate for that in a fee-for-service environment is to increase the productivity level of your staff. And I can remember at a time when staff could perform 4.5 billable service hours a day, and the organization would still have an operating margin at the end of the year. And increasingly, those pressures have gone up, so that in many environments, unless you're producing at 60 or 70% of your time is in face-to-face service delivery, the organization can't afford to stay afloat. They can't meet their overhead, they can't increase salaries, they can't increase benefits, and it's kind of a vicious circle. And I think nothing is more stressful for a CEO of a provider organization to be sweating every payroll and wondering whether you have sufficient cash reserves to be able to meet your next payroll cycle. And we need structures to support the current workforce as well. We need to give them the tools, particularly the technology, to be able to work effectively and efficiency. And we don't have enough in the way of any research and evaluation to see what it takes to build adequate supports to recruit and adequately train and retain our workforce. So what does the workforce itself tell us? Well, the Kaiser Family Foundation issued a report just this year, and there are basically 4 buckets that they identified what is needed to adequately address the workforce crisis. And the first always are payment rate increases. But again, if you look at the mood in state legislators around the country, or oftentimes in the US Congress, increasing taxes to be able to pay more for services is not something that people have an appetite for. Everybody's looking at cost containment as opposed to increasing rates. The second thing has to do with administrative burden reduction. I think back to my early days in this field, working in a community mental health center. In those days, they were all started with federal grants. There were 8-year diminishing grants, and mental health center got paid 1/12 of its budget every month to meet its costs. And then the shift began around moving to fee-for-service, particularly as provider organizations became dependent on Medicaid. And in those early days, we didn't have any electronic health record. We didn't even really have health records to speak of. We would have a manila folder, and we have a piece of legal tablet in that manila folder that we would keep progress notes in. There was even no treatment plan, no service tickets, etc. Whereas today, the adage is that if it's not documented, it didn't happen unless all the I's and T's are crossed relative to submitting claims in order to be paid. You don't get paid. And so in addition to being increasingly productive, the push is always meeting those bureaucratic requirements so that an organization can get paid for the work that you did. The third has got to do with workforce extension, and that can come in a myriad of forms. And I talked a bit about the introduction of peer support as extending the workforce, but there are a variety of other things that can also extend the workforce that we'll touch on. And then having incentives. When I think back to when I did a management turnaround of an inner city mental health center in Ohio back in around 2002, this organization was crashing and burning because they needed 4.5 hours of billable service a day per clinician in order to meet their annual budget. And we're only producing 2.5. And when I was contracted to assist with getting this organization on a pathway to be financially sustainable, I basically made a deal with the union and with the staff to partner with me in coming up with a way to get to a minimum of 4.5 billable services a day. And so I offered them, let's say, for the sake of argument, on average, for an hour of service, the organization would get reimbursed $100. Well, if that $100 was for an hour of service beyond 4.5 billable service units per day, then that was $100 that basically was gravy. That was what we would refer to as an operating margin. And so I said to the staff, here's my deal with you. For every hour beyond 4.5 hours that you put in a pay period, I will pay you an incentive of $25, which meant that the organization would net 75. And by virtue of doing that and a host of other things I won't go into, the staff became very invested to increase their own financial participation in delivering services, as well as sustaining the organization as a whole. Oops, I'm sorry, I missed one. You're probably all familiar with the National Council for Mental Well-Being. It's changed its name a number of times over the last few years, but they surveyed their membership, and they had about 206 provider organizations nationally that responded. And the number one identified issue that the National Council recognized was that demand for behavioral health services has continued to increase, and that a result of that phenomenon, that there was an increased demand, was causing their patient wait lists to grow, and organizations, number three, having trouble recruiting and retaining employees of workforce sufficient to be able to respond appropriately to the increased demand. So let's talk about what can we do about all this? What are some potential solutions? They seem to fall into three buckets. One's got to do with funding and financial incentives, ways to optimize access, actually, to the available behavioral health workforce, and the other thing that we touched on earlier about waiving burdensome documentation and administrative requirements, and then the states developing some performance metrics and data collection methodology around being able to measure performance over time to see whether or not any of these strategies are actually working. So if we look at the first of these, increasing funding and financial incentives, I'm not going to go through each of these individually, and you can certainly read them on your own. But I think the heart of this matter is not limited to tuition assistance and low repayment plans, although I think those are important solutions, and getting the Human Resource Services Administration, HRSA, beginning to do a better job of loan repayment programs for people serving in underserved areas around the country. They've been very good at that with healthcare in generally, but not with behavioral health. But I think the number one thing that needs to happen is moving away from fee for service. It's really breaking the bank, for all of our systems. And the brightest thing on the horizon over the last half a dozen years or so has been the emergence of CCBHCs, Certified Clinical Behavioral Health Centers. The reality is that community mental health centers and federally qualified health centers came on the scene in the late 60s, but were financed very differently. So the promise of community mental health centers has never been realized, whereas federally qualified health centers are reimbursed on a prospective cost-based reimbursement system. So as their costs increase, their payment through Medicaid increases as well. That's not true for the community mental health system. So CCBHCs, by virtue of this very different payment methodology. And there are now over 500 CCBHCs around the country that do a number of things. One, they integrate primary care with behavioral health care. They integrate mental health services and substance use disorder services. They serve adults and children, youth, and families, not necessarily always under the same roof, but under the same entity. And as I said earlier, as their costs increase, so does their reimbursement. And these rates are actuarially determined. If you look at the state of Oklahoma, which was an early adopter of CCBHCs, they're the only state that I'm aware of that reports that they no longer are challenged in terms of workforce recruitment and retention. Because of this change in payment methodology, they are able now to increase salaries, benefit structures, being able to do the things that retain staff in terms of adequate training, supervision, staff development, etc. And so they've been able to have above market salaries and signing bonuses and benefits, etc., to basically recruit staff from other states, which exacerbates the problems for the rest of us. But it's a good example of what the power of CCBHCs have in being able to change this. Another, but lesser known tool is for a state to get a CMS waiver to develop behavioral health homes. And behavioral health homes serve an identified population that's approved by CMS at the federal level that integrates behavioral health and physical health care, and also gets paid on a prospective cost-based reimbursement, which has a similar kind of effect. In New Mexico, we had a planning grant for CCBHCs, and we were one of 26 states to be awarded that grant, but only 8 states were funded for implementation. And I knew that given how bifurcated our delivery system is in New Mexico, in that adults are a very different system than that serving children, youth, and families, that we weren't going to be able to qualify. So we went the route of behavioral health homes. So that's another potential solution that I would like you to potentially consider. We want to optimize the access to the available workforce, and one of the options here that I think is absolutely critical is to adopt an open access model. Particularly if you are an organization that still operates on fee for service. The no-show rates in our provider organization can be anywhere from 20% to 50% and beyond. And where do we, I'm sorry, I don't know why that happened. Well, let me go on. And the reality is, given a no-show rate, you always have providers who had an appointment scheduled, and now nobody's here to fill that slot. And yet, as the organization, you're responsible for paying that person's salary for that hour, their benefits, all the overhead, keeping the lights on, support staff, etc. So you have all these costs, but you've got no revenue to offset it. So you have staff available, and staff a lot of times, quite frankly, love having no shows because then they can catch up perhaps on their documentation, or they can kibitz with their colleagues, etc. But the reality is that it's devastating to the financial performance of a provider organization. So if you take that capability and realize that in, say, in an 8-hour shift, you've always got people who are down, who are clinicians. And if you change your model, so rather than scheduling appointments, that you allow people to walk in on a first come, first served basis, and you can immediately provide people with access to services. It makes all the difference in the world. Instead, what have we historically done? We wait until people are at a point of crisis. People are in sufficient pain to be motivated enough to seek help. And then when they finally get an appointment, which can take 2 weeks, 4 weeks, 6 weeks to get an intake for a clinical assessment, what do? We don't focus on the person's needs who's coming to see us. We're more concerned about what our bureaucratic needs are. So we spend all of our time on meeting those bureaucratic needs. And then we wonder why the no-show rate for the second appointment, and this has been the same as long as I've been in this field, is as high as 70% for that second appointment, because people came to us for help. They reached out. We didn't listen. We didn't hear them out. We didn't meaningfully engage them. If anything, we tended to alienate them, estrange them, etc. And so they don't come back. And then we're frustrated and angry and feel like, well, we had to open up this case, we had to meet all these documentation requirements, and then the person doesn't show. And it just exacerbates and becomes a self-reinforcing cycle. What we did in New Mexico and said, this is something we've been doing for decades, it's got to change. And we implemented what we called Treat First. And what this was about was giving providers the ability to take up to 4 sessions to complete the intake and psychosocial assessment. And so they really began to switch it up by virtue of getting certified as a Treat First organization. They could put a peer support specialist at the front door, somebody who can listen, can relate, can talk out of their own experience, and meaningfully engage people who are showing up in pain. And nobody's better qualified to do that than peer support specialists. And that can then be followed up with clinical interventions and eventually the treatment plan. So there are 4 sessions for provider organizations to be able to do that. And we reduced the no-show rate at an average of 70% for the second appointment down to 17%. And that's continued to carry the day years after. So it's another potential solution that I encourage you to take a look at. So access is relatively, or is critically important. The ability to build out your 988 crisis response system is equally important. I'm just checking the time here for a minute. I don't know if you're familiar with Crisis Now, with the SAMHSA national guidelines for behavioral healthcare crisis response, and the new youth guidelines from SAMHSA as well. But in that model, we're really talking about providing accessibility 24/7, 365 days a year. That begins with a 988 call center hub that's technologically enabled with GPS, with a bed registry in real time, so that whether it's the call center or mobile crisis teams or any other provider in the state, can know where the nearest available bed is without having to hunt for one, which is terribly inefficient. And by the time you find one and you get somebody transported, that bed may have already been filled. In addition, having real-time outpatient scheduling. So if a mobile crisis team goes out at 2 in.the.morning and intervenes with somebody under a bridge in some community, and they want them followed up at the nearest community mental health center when they open up at 8 o'clock the next morning, they can go ahead and schedule that appointment. They don't have to wait 4 to 6 weeks to be seen subsequently. The second piece of that are mobile crisis teams made up of a clinical professional and a peer that can respond anywhere, anytime, any place where people work, live, and play. And most calls can be stabilized by the crisis call center, roughly 90%, which means only about 10% need a deployment of a mobile crisis team. And a mobile crisis team on average can stabilize 70% of the folks that they intervene with in the community. That means about 30% need a higher level of care. And that's where having facility-based crisis services is absolutely critical. That begins with a crisis receiving center that operates with recliners instead of beds, because you want to have no wrong door. You never want to be closed. You never want to be on diversion status. But if you have a 16-bed unit and the 16 beds are full and somebody presents at the front door, you have to go on diversion. You're not available. State licensure law requires that you not admit more than the 16. Whereas the crisis receiving center operating with recliners doesn't have those kinds of limitations and has more flexibility to manage flow, and people stay in the crisis receiving centers for under 24 hours. And roughly 70% of those folks can be stabilized in under 24 hours. Then that is paired up with a crisis stabilization unit with beds where folks could stay up to 2 weeks. And these centers should be able to take voluntary and involuntary admissions. Mobile crisis teams need to be able to transport involuntaries to crisis receiving centers. They've got to be able to serve those with mental health, SUD, and IDD issues. And the goal is to say yes 100% of the time. And they've got to be able to take folks from the back of a police car, which we do 60–80% of the time. And we guarantee the police that they're off the premises within 3 to 5 minutes. And I could talk to you for hours about how we make all of that work. But the work is meaningful, it's responsive, it makes a difference in people's life. But the chief point here is, again, this provides immediate access. So that's more on access. I don't know that I necessarily need to expand any more of that on that. But one of the things that, going back to community ownership, we need to be able basically to build our own. And what do I mean by that? The reality is we talk about psychiatrists, for example, which there's a tremendous scarcity of, and child psychiatry is even worse. That is because all of the medical schools have been capped in terms of the number of people that they can graduate on an annual basis, which restricts the pipeline of new people entering the field. And that hasn't changed for decades. But one of the options we have available to us is to do community-based residencies, which is one of the things that we've been doing in New Mexico for a long time through the University of New Mexico. And by virtue of placing psychiatrists who are residents in rural communities, we found over time that 60% of those who serve their residency in a rural community will choose to stay in that community. Whereas if you tried to recruit a psychiatrist into those communities, it would be near impossible. And if you were successful, it would mean you'd have to spend a great deal on an executive search. And in addition to that, the salary requirements would probably be beyond what a rural community could afford. Likewise, we worked with the Western Interstate Commission on Higher Education to establish a community-based psychology internship. And with that program, we found a similar kind of outcome. 60% of the psychologists who do their internships in local communities in New Mexico stay in New Mexico. Two things I think that would improve that retention rate is, one, oftentimes you've got to be able to offer housing as well. And in many rural communities, there isn't necessarily the housing available to accommodate a professional coming into the community. And in addition to that, if they're married, there's got to be employment opportunities for the spouse. So if you can overcome those two challenges, I think you're going to be on the right path to begin solving some of these provider shortages in areas that are particularly challenged with these issues. This issue of administrative burden, again, I refer you back to what I said earlier about treat first as an option. Another is having an expectation and a capability and appropriate training and supervision around concurrent documentation. Usually when you talk about this to clinical staff, there's often resistance that this will alienate our clients, and that's the last thing that they want to do. In my experience, if you adopt doing concurrent documentation and use it as a way of engaging the people you're working with, validating with them that this is what you understood, this is how you began documenting your session, this is what the treatment plan looks like, and you develop it in collaboration with them, etc. It serves everybody's interests. I think it offers greater clarity, transparency, engagement, etc. With our clients. But you've got to be able to have the technology to be able to do this. And this is even truer now that we're doing more virtual work and telepsych work and mobile crisis teams and being able to do adequate supervision remotely. All of these things end up being important responses to the crisis that we're facing. When we talk about remote supervision, oftentimes professional licensing boards require that supervision be face-to-face. And we had to do a lot of work with our licensing boards, and there's still a couple of holdouts to put into their regulations, allowing for virtual supervision. Where this particularly makes a difference has to do with all of the people you find in any locality who went to graduate school, got a graduate degree in one of social work, counseling, etc., but never got the 2 years of supervised clinical experience in order to qualify for independent licensure. Once we got those rules changed in our professional licensing boards, we worked with the University of New Mexico and contracted with them to provide remote supervision so that those, particularly working in rural communities where either independent supervision wasn't available, or their private practitioners are hanging their shingle out and charge $150 to $200 for an hour of supervision that a lot of these folks can't afford. It became a way of, again, extending the workforce, and it was an unmet need that for a long time we haven't recognized. I'd like to go back to the pipeline idea. All the things that we've talked about today aren't upstream enough. We have to find ways. Some states are doing better at this than most of us, around attracting young people, giving them exposure, experience, immersing them in some of our settings to learn about what it is that we do, so that we can begin to generate enough flow, if you will, so that the pipeline's full and we can begin to create practitioners, which may be a multi-year, sometimes decade-long process before they're actually practicing. And two services that I think are critical, that some states have well developed and others not, is being able to offer supported education and supported employment. So with that, I know there was a lot there and a lot more that I could say on these subjects. I might close by saying that increasingly I feel like individual therapy is the luxury that the system's challenged to continue to offer. But getting mental health practitioners to do group treatment, I have found can be particularly challenged, but I know I spent a lot of years in the addiction field, and that was our preferred modality. So I know that it can be done, and we should be doing much more group treatment, family therapy, intensive outpatient programs, ACT teams, etc., than always insisting that our service delivery be individually focused.